So let's go to question number 16. So we're already halfway through. Yes. So let's open the polls. So which of the following is not a feature of trigeminal neuralgia due to multiple sclerosis? So this is an indirect question. So basically I'm asking you, which of the following is not a clinical feature of a secondary trigeminal neuralgia? Okay. So we have primary trigeminal neuralgias and secondary trigeminal neuralgias, and they have totally different demographics, totally different clinical presentations and treatment also. Yeah, good. Many of you are answering it right. Okay. Maybe you're getting it right in the chat box too. Okay, so we'll conclude this. Great. So more than 50% of you have got it right. So let's analyze this MCQ. Okay, so which of the following, so let's see which of the following is not a feature of multiple sclerosis trigeminal neuralgia or a secondary trigeminal neuralgia. So onset before, so when you take a patient with multiple sclerosis plus a trigeminal neuralgia, so usually the age of onset is less than 50 years. Okay. Usually it's less than 50 years, and the symptoms are usually bilateral, and the patients have associated sensory loss, and number 4, presence of non-paroxysmal symptoms. So these are the features of a trigeminal neuralgia because of a demyelinating illness. So younger age of onset, bilateral symptoms, presence of objective sensory loss, and non-paroxysmal symptoms. So just invert this. This is the features. So the opposite of this will be the features of a primary trigeminal neuralgia. So if you take a primary trigeminal neuralgia, usually it's a disease of older age. It's usually a elderly female patient, somewhere around 60s or in the 70s. It's most of the time unilateral. And when you do a clinical exam, there is no sensory loss if it's a primary trigeminal neuralgia. And the symptoms are paroxysmal, okay, lancinating and paroxysmal in a primary trigeminal neuralgia. But in a secondary trigeminal neuralgia, because of multiple sclerosis, it is non-paroxysmal. In addition to paroxysmal pain, you can have non-paroxysmal. So the answer is 2. So this is the this is the false answer. That is, it is the answer. So there is no objective sensory loss. No, in multiple sclerosis, we will have sensory loss if it's causing trigeminal neuralgia. So trigeminal neuralgia in multiple sclerosis, just to revise, onset less than 50 years, that is young age or onset. Bilateral symptoms, very, very important. Presence of objective sensory loss and the presence of non-paroxysmal pain in addition to the paroxysmal pain. So great, we'll go to the next MCQ. So let's open the poll. So we have a 40-year-old female patient presenting to the neurology OPD for review. She is a known case of multiple sclerosis and she's on interferon therapy. And she complains of blurring of vision after a hot shower. So what is this known as? I'm sure most of you are going to get it right. Okay, but I just want to bring it out again so you can revise. Great. And as I mentioned, all of you have got it right. Not even one wrong answer. Okay. So since all of you have got it right, I want you, the toppers in the chat box, to tell me what is Pulfrich phenomenon. Okay, or just the gist of it. Cox phenomenon and Bell's phenomenon are just red herrings. I just kept it as decoy options. Forget about those. Uttov's phenomenon is the right answer. Okay, so we'll end the poll. It's great. Most of you have got it right. Does anyone want to tell me in the chat box what is Pulfrich phenomenon? So the highlight of this point is in multiple sclerosis or any other demyelinating illness, it is temperature sensitive. Okay. So sometimes these patients come with pseudo exacerbations. So basically they're a case of MS with already multiple lesions in the MRI and they get a fever or they are exposed to some sort of warm climate. So what this does is already their saltatory conduction is impaired because of conduction block and demyelination. So actually temperature slows the nerve conduction velocity even more. So it brings out the pre-existing symptoms in these patients. So a patient who has already had an optic neuritis or something, when they're exposed to higher ambient temperatures, there can be a transient worsening or a re-emerging of the old neurological symptoms. So this is what is known as Uttov's phenomenon. So I'll open the chat box to see about yeah, great. So Sapna Mittal has answered the right answer. So Pulfrich phenomenon is actually an alternation in the depth perception. So basically in Pulfrich phenomenon, what happens is, so the optic nerve the impulses are going very slow to the visual cortex. So because of this, there is some issue with the depth perception. Okay. So patients don't perceive the depth or the distance between them and the object. So what is actually viewed as two-dimensional may actually appear as three-dimensional. So let's take an example of a pendulum. Okay. So normally when we see a pendulum, it usually, we perceive the movements in a two-dimensional view. But in a patient who's having an optic neuritis and multiple sclerosis, this Pulfrich phenomenon, what happens is this depth perception or the 3-dimensional or 2-dimensional perception is totally distorted, and the patient may actually visualize the pendulum going in a circular pattern. Okay, and this is just nice to know. Okay, so just remember, Pulfrich phenomenon, the keyword is depth perception, and Upthau's phenomenon is actually heat sensitivity. Okay, so as we discussed, Upthau's phenomenon, and it's because of, and the underlying reason for this transient worsening is because of a transient conduction block because of increased ambient temperature. Okay, great. We'll go to question number 18. So which of the following is false regarding the paroxysmal symptoms in patients with multiple sclerosis? Okay, we'll open the poll. So we have also a set of ancillary or paroxysmal symptoms in patients with multiple sclerosis. Okay, so this could be a paroxysmal vertigo, a paroxysmal ataxia, something like an extensor or tonic spasms. So we have a wide array of paroxysmal symptoms in multiple sclerosis. And the reason for this paroxysmal symptoms is actually usually at the edge of the demyelination, there is some sort of abnormal depolarization. So that is the usual reason. So which of the following is false? Okay, that's great. Most of you are giving the right answer. Oh, almost more than 75 are giving the right answer. Yeah, Sehad Singh has asked Pulfrich occurs in which disease? Actually, it occurs same in multiple sclerosis with optic neuritis only. Both Pulfrich and Upthau's happens in optic neuritis. Okay. Okay, we'll conclude the poll. Most of 80% of you have got it right. Okay, that's great. And we'll continue the class. Yeah. So we'll analyze this MCQ. So paroxysmal symptoms in multiple sclerosis. Sorry for the spelling mistake. Okay, so it lasts for a few seconds. Yes. Low frequency, no. Actually, it is high frequency. Okay, it happens multiple times per day. Okay, so paroxysmal symptoms in multiple sclerosis is high frequency. Yes, the patient has an intact consciousness as well as a normal EEG. Okay, so sometimes it can be confused with an epilepsy or seizures. So the patient's consciousness is intact and EEG is normal. And an example is Lermit symptoms. Yes, Lermit symptom is an example of paroxysmal symptoms. So let's rush through the facts. So paroxysmal symptoms in MS, they are brief duration, usually a few seconds to a few minutes. Very high frequency, they occur around 5 to 40 times per day. And however, the patient's consciousness is totally normal. There is no change in the background EEG, and it's usually self-limiting. It usually resolves within a few months. And important examples, okay, so this could be a possible MCQ: Lermit symptom, tonic spasms, paroxysmal ataxia, paroxysmal dysarthria, and as well as paroxysmal sensory disturbances. So, and just an interesting question for those who are interested, you can try answering this chat box. So I think most of you know what Lermit symptom is. So basically, I'm sure you know that. I want those in the chat box can tell me what is inverse Lermits and what is the reverse Lermits. Okay, or maybe you can send me the messages. I'm on Instagram, same name. Maybe you can text me after the class because of want of time. So we'll go to the next MCQ. Okay, so question number 19. So which of the following is the most common type of multiple sclerosis? Okay, it's a very easy question. I've just brought up this MCQ so we can discuss the different types. Is it relapsing MS? Is it primary progressive MS? Is it benign MS? Or is it a secondary progressive MS? Okay. So most of you are getting right. Okay, a lot of participants. Great. So most of these MCQs, guys, I've actually based it on Harrison. I've kept it as simple as possible. I didn't want to go further than Harrison because I think most of the my target audience is preparing for NEET SS. But for those who do want to prepare for NEET SS neurology, you can contact me. I'm there on Instagram, and I can send you some materials. And also, I've also made a question bank for Surgtest, and my notes I've also put it on Surgtest. So most of my content is actually based on Bradley, Harrison, Adam, and Victor. So those who are specifically preparing for NEET SS neurology or who want to know a little more about it, you can talk to Surgtest, the concerned admin people. So the QBank and notes is there on the Surgtest app. And you can also, if you want to have any personal queries, you can text me on Instagram. So great, guys. We'll close this poll. So most of you have got it right. I think very brilliant crowd. So the answer is actually RRMS. Yeah. So the answer is RRMS. So RRMS is actually 90% of all MS is actually RRMS, and 10% of MS is PPMS. So we'll just go into the types. So this is a very illustrative graph that is given in Harrison. So here this is relapsing remitting MS. So basically what happens is the patient has frequent relapses in neurological symptoms, but in the intervening time, the patient is neurologically quiescent or normal. But however, in the true sense, this is not true. And Harrison also has highlighted that in this diagram, because eventually over time, the patient actually does develop some sort of interictal disabilities. Okay, so initially maybe RRMS, the other than the periods of the acute relapse or attacks, the patient might be normal, but eventually over time, they actually do accrue very subtle neurological deficits. And very important, remember that 1 to 2%. Okay, so it's a little controversial percentage. I think earlier it was 3%, but now it's around 1 to 2%. So 1 to 2% of RRMS patients will convert into SPMS. That is a secondary progressive MS. So secondary progressive MS is just like RRMS. It has relapses, and it has relapses and remissions. But after the relapses and during the period of remissions, the patient slowly accrues neurological deficits. So RRMS will have only attacks. In between, they will be normal. But in SPMS, secondary progressive MS, they will have relapses. But in addition to the relapses, they will have worsening neurological symptoms. And then we have PPMS, a very interesting one, and sometimes very difficult to diagnose actually. So this is 10% of all MS cases. The patient does not have any relapses at all. Okay, so they're not going to present to you acutely with a myelitis or an optic neuritis, but over time, slowly, they slowly acquire focal neurological deficits. So it is primary progressive. So these are the three types. Please remember, important facts here is the most common one is RRMS. PPMS is 10%, and 1 to 2% of RRMS will convert annually into a secondary progressive MS. Okay, guys, we'll go to question number 20. So we have 10 more questions after this. So which of the following is false regarding primary progressive MS? We'll keep the chat box open. I'm very sorry that I have not finished within an hour. I think I should time myself in the next class. Okay, but anyway, we'll complete this. Okay, little tough question. It's taken from a very short excerpt in Harrison. It's also a very important demographic factual question. Okay, now most of you are answering it right, but only 6 have answered, 7, 8. Please, more of you should try. Okay, so I guess this is the tough question. There is a lot of competition between option B and option C. So I'll end the poll right now and we'll analyze this MCQ. But I'm very happy that all of you tried. So which of the following is the false option? Okay, so let's analyze this. So already we know this 10% of MS is because of PPMS. So this option is correct. Early age of onset compared to RRMS. Okay, so actually this is the answer. This is the false statement. So actually if you take RRMS, usually the age of onset is around 20 to 40 years. But when you take primary progressive MS, when you take PPMS, primary progressive MS, the age of onset is a little older. Okay, it's around 40 years, just like in NMOSD. And very, very important, even sex distribution. Sorry, it's not that. This is actually true. I mean, it's a true fact. So if you take RRMS, male patients, if you take RRMS, female patients are more involved than male patients. But if you take primary progressive MS, more or less this sex distribution is even. Okay, so these 2 points, don't forget, later age of onset and a more even sex distribution. And yes, as per McDonald's criteria, the patient should have 1 year of disease progression. The patient should have 1 year of disease progression to diagnose as PPMS. So these are the important facts. Let's rush through them. So 10% of cases, sex distribution is more even. That is, males and females are more or less equally involved. In contrast to RRMS, where females are more commonly involved. And the onset is later in life, very, very important, at 40 years. And it is a very disabling illness, okay, compared to SPMS as well as RRMS. PPMS is very, very disabling. Okay, the patient is going to be having very high EDSS scores and is very likely to be wheelchair bound very early into the illness. So this is the McDonald's criteria for PPMS. I'll be discussing another MCQ about the actual McDonald's criteria. So remember, this 1 year is a very important possible MCQ. So patient should have 1 year of disease progression, either retrospectively or prospectively. Plus, the patient should have 2 of the following. So number 1 is evidence for dissemination in space. Okay, the patient should have evidence for dissemination in space based on 1 or more T2 hyperintense lesions in the MS classical regions. So what are the MS classical regions? This is also an important MCQ. Periventricular, juxtacortical, infratentorial, as well as the spinal cord also, that they have mentioned separately here, evidence for dissemination in space in the spinal cord. So actually Harrison's has not updated this and has not updated this, unfortunately. So like I mentioned, there are 4 classical areas for MS. So one is periventricular. This most of you know it. One is periventricular. Next one is juxtacortical. Okay. So the important addition that is made in the 2017 revision of McDonald's criteria, not only juxtacortical, but even cortical lesions is taken as an MS classical site. So please don't forget this. It is not mentioned in Harrison. Okay. So both juxtacortical as well as cortical lesions is taken for dissemination in space. It is an MS classical area. And then third one is infratentorial. So this is mainly cerebellum and the brainstem. Infratentorial. And the fourth one is the spinal cord. So like you have the 6 core characteristics in NMOST, these are the 4 important areas that are involved in MS: periventricular, juxtacortical, infratentorial, and spinal cord. Please don't forget, it's not given in Harrison. That's why I've added it. Cortical lesions are also added into the MS classical areas in the 2017 revision of McDonald's. And for this PPMS, don't forget this 1 year. Okay, so PPMS, this is a McDonald's criteria. Don't forget 1 year plus 2 out of 3 of this. And the third and most important one, positive CSF oligoclonal bands. Okay, so we will come to this oligoclonal bands and the importance in McDonald's criteria in another MCQ. Okay, so very easy MCQ, factual MCQ. We'll rush through it fast. Only 30 seconds, guys. Okay. So which of the following vitamin deficiencies is associated with multiple sclerosis? Very easy one. I'm sure most of you are going to get it right. Okay, we'll conclude, guys. Most of you have answered the right option as expected. So the answer is vitamin D. The answer is vitamin D. So vitamin D deficiency is associated with multiple sclerosis. And this is probably the reason why multiple sclerosis is very common in the Scandinavian countries and areas more in the Western hemisphere, where sunlight exposure and vitamin D and is very, very common. So what are the risk factors for MS? So you guys can try in the chat box till I finish typing it. So one is vitamin D deficiency, as we mentioned. Number 2 is genetic. Okay. So genetic will be the next MCQ, which HLA is very important. Next is Epstein-Barr virus infection, but Epstein-Barr infections which are acquired after early childhood. Okay, not the ones that are acquired during childhood. So basically, adult EBV infections is a risk factor for multiple sclerosis. Anything else? The last one, anyone wants to try? Yeah, so I see your answer on HLA. There's an update in the 21st edition, which I'll come to. Yeah, great, Priyanka. The answer is smoking. So these are the proven risk factors. Okay, so these are the proven risk factors for multiple sclerosis: vitamin D deficiency, genetic, which will be coming to, and Epstein-Barr virus infections that are acquired after early childhood or in adulthood, and also cigarette smoking. So don't forget this very, very important fact. So question number 22. So which of the following predisposes to multiple sclerosis? So guys, this is a update from 21st edition of Harrison. I think 20th patient, most of you who have read the 20th edition might differ, but this is just an update. They've given a more specific HLA. That's all. It's not that it's an update, but so I'm sure most of you know that HLA B1502 is not the answer. So anyone in the chat box can tell me what is the importance of HLA B1502 in neurology. It's very, very important HLA in neurology. We test it very, very often in the epilepsy clinic, at least where I am doing my residency. Okay, so we'll stop this poll. Okay, so stop the poll. So the answer is HLA-DR15. So let's go into this. It's basically a factual question. So HLA-1502, anyone wants to answer in the chat box? Anyone wants to answer in the chat box? 2 minutes time. Okay, fine. So just remember HLA-DR15, and actually HLA-DR15 contributes to 10% of the this one. 10% of the disease risk. So looking at the chat box. Okay. So HLA B1502. So maybe you guys can get back to me after the class. What's the importance of HLA B1502 in neurology? Okay, but the answer over here is actually HLA-DR15. You can refer the Harrison 21st edition. It's mentioned there.